Now, digitalis glycosides. This is an important topic. The cardiac glycosides are often called digitalis glycosides. Most of the drugs come from the digitalis foxglove plant, and there is that is low therapeutic window, that low therapeutic index, and so toxic or fatal dose can occur. Only available agent is digoxin. The mechanism of action is inhibit the sodium potassium adenase triphosphate enzyme. Okay, digoxin will inhibit this exchange, reduce the ability of the myocyte to actively pump sodium from the cell, and result in increased free calcium and leading to increased cardiac contractility. The concentration of sodium will increase because its outgoing will be blocked. Then calcium will be released more and more, and so the contractility will be enhanced. Increased contractility of the cardiac muscle. You can see here, this is the symptoms of adequate output such as fatigue and voluntary cardiac output. Now first, in normal heart rate, what happens? You can see here A. Within limits, when cardiac muscle is stretched, force of contraction increases, cardiac output increases. If ventricular is overly stretched, effect of ventricular contraction is diminished. A is the normal operating point in the healthy heart. Now, decompensated heart failure. Initial reduction of contractility A to B due to heart failure. Symptoms of low cardiac output develop, for example, fatigue. Third, compensated heart failure. Ventricular end diastolic pressure increases B to C. In an effort to maintain adequate cardiac output, the increased ventricular end diastolic pressure causes symptoms of congestion, for example, dyspnea. Then what occurs? Digoxin treatment comes here. Administration of digoxin at the dose that cause positive entropy shift the ventricular function curve towards normal, increasing contractility from C to D, leads to increased cardiac output. Decreased sympathetic reflexes and vesicular tone causes a decrease in the ventricular diastolic pressure from D to E. This is an important graph for digoxin. Okay, now neurohormonal inhibition. The exact mechanism is not known. Therapeutic uses. Patients with heart failure of reduced ejection fraction. And dose is very minimal, 0.5 to 0. A low serum drug concentration is beneficial. This is serum drug concentration. It is available in oral and in injectable. It has large volume of distribution. Long half-life, 30 to 40 hours. Adverse effects: at low drug serum concentration, digoxin is well tolerated, very low narrow therapeutic index. Anorexia, nausea, vomiting, blurred vision, yellowish vision may be initial indicators of toxicity. When the ATPase is markedly inhibited by digoxin, the resting membrane potential may increase, which makes the membrane more excitable and increasing the risk of arrhythmias. Decreased level of potassium, hypokalemia predispose a patient to digoxin toxicity. Digoxin normally competes with potassium for same binding site on the pump. So with the use of lower serum drug concentration, toxic levels are infrequent, and it should be used in caution with beta blocker, verapamil and diltiazem. Beta adrenergic agonist. You can see here, binding of beta adrenergic agonists such as dopamine, dobutamine activates adenylyl cyclase, which produces CAMP. CAMP activates protein kinase, which in turn phosphorylates the calcium channels. Phosphorylation of calcium channels increases calcium flow into the cell, causing increased photofaction into the heart muscle. Phosphodiesterase inhibitors prevent the hydrolysis of SCAMP, thus prolong the action of protein kinase. They inhibit this action. Phosphodiesterase inhibitor milrinone is an inhibitor which increases the intercellular CAMP. Now, recombinant B-type natriuretic peptide. Most often, IV diuretics are utilized in the acute setting to reduce preload. When IV diuretics are minimally effective, this B-type natriuretic peptide or necitritide can be used as an alternative. It is administered IV, short half-life 20 minutes, and hypertension, dizziness, diuretic. Order of therapy. You can see here. Risk factor of reduction. Patient education. Stage A, high risk but no symptoms. Now, next you have to treat hypertension, diabetes, dyslipidemia with ACE inhibitor or ARB in some patients. ACE inhibitor or ARB. Stage B, structural heart disease, no symptoms. ACE or ARB beta blocker in selected patient. Stage C, structural and current symptoms, ACE, beta and aldosterone antagonist and in selected patients. Replace any ACE or ARB with an ARNI. Dietary sodium restriction, diuretic, digoxin, avobratin.